Hello everyone, this is Dr. Khan, Executive Plastic Surgery, Bloomfield Hills, Michigan. So as you will see, this is a pleasant 40-year-old lady, 40-year-old lady. She had implants just from 2013, so just 11 years ago. She got imaging for an abdominal problem that she was having, and the next thing you know, incidental finding of what is a ruptured implant on a CT scan. Then she went and got an MRI only to prove that her left breast implant from just 11 years ago was ruptured. So she comes to me, she technically really didn't want the surgery, but she was, because of the rupture, had to proceed. So this is complete and block 10-24-24, initials SR. I cut out this scar, as you will see, like a very prominent scar. And as you will see, I'm very happy and content with how the whole dissection went. Look at this, this is nice and round and contained, but look at this one. This is an outpouching, and we're going to see that shortly. So complete capsule removal. This was a relatively very tedious surgery. I'm just getting done with my first surgery. Blood loss literally was 3 cc's on each side, and as I go in, overall I'm very happy and content with how the whole dissection went. And as I go in, you can see, look how thin this capsule is. And no matter how thin, it has to be removed. Look at this. So intact implant. And as I go in and I remove, there's some fluid behind it. So I'm just going to go ahead and pick it up with my new gloves. And you will see, look at this. What is this? Leaching of that silicone, the stickiness. This is not good stuff. This is the one that's the culprit, supposedly. This is the 455 Mentor implant, intact, as you can see, just from 2013. So I'm going to rest this here, and as you will see, a capsule tissue that's so thin you can see my glove right here. Now what I'm going to do is, let me go ahead and, while I change my gloves, I want to go ahead and focus on this Khan procedure. No lift needed, no drains required. The high definition photos and videos of the chest wall, and also cutting open of that capsule, returning the implants to the patient, even if they're ruptured, so the patient can see what was inside her chest. Pathology, rule out malignancy, breast cancer, rule out anything abnormal. Microbiology cultures for aerobic, anaerobic, and fungal. Twilight deep sedation anesthesia. Every patient gets sub-Q heparin, STD boots, out of bed to cheer on day of surgery, and the following day ambulation with assistance, all precautions. And all patients, regardless of their comorbidities, get their surgery with total capsule removal, so that we don't have to worry about this. Now, as you will see, full thickness scar plus this, that helps with it with the contouring. Now I've changed my gloves. Look at this capsule. Literally, this was sitting over here on this part, and you can imagine this was under the muscle, and you can see the muscle part of it is above. You can imagine if she's working out, you can see how it's outpouching, not only here but here certainly. And you can imagine when you have a known rupture, this is contained. You don't want it to break and spill outside, and now you have free flowing silicone on the outside. Now remember, this is 2013, done en bloc. You can already see how thin the capsular tissue is. If someone is going fast, if you will, during the dissection, you can easily imagine you can amputate this off. Now remember, when you put pressure on it, it outpouches as if it wants to jump out, and you can see it's super thin. I'm actually going to enter from here just so you can see. I can actually take my finger and press this in all the way in. And look at this. And this is where it is a contained rupture, none of this spilled into the chest, and no need for drains. And this is the whole essence and etiquette of the surgery. You have to always assume that the implant's ruptured till proven otherwise. So as I go in, like I said, I'm going to go in from here, and I'm actually going to hold this tissue. It feels good to do this now, and you can see, look, how instantly you have this ruptured implant. A lot of inflamed tissue around it. It was a very difficult dissection, as you can imagine. So as I go in, I want to show you how thin this capsular tissue is. This is supposed to be the nicer, better, safer gummy bear. And I'll tell you, there is nothing gummy about this implant. I just did a few days ago an implant from 1979. This implant from 2013, it has all of this, and you can see it's like molten. And we don't want this to spill into the chest. It was all contained. And you can see literally the implant is being like blasted off, if you will. Let me go ahead and see. This is the shell of that implant. Let me go ahead and tease this off so you can see how this implant literally is like wet, if you will, and this is the shell of the implant. So the consistency of this is very different compared to the internal contents. And as I go in, and this is the other take-home message, everyone has to assume that the implant's ruptured till proven otherwise. In this case, she had the incidental finding. You can see as I work this out, some areas are so thin, some areas thick, and it doesn't take much. So if I put the ruler here, you will see it is so thin you can read right through it. So, number one, there are many things we learned from this case. The gummy bears are the same as the ones before in 1980s that ruptured, and as you can see, they're not like they were like this one. If I take a knife and cut it, this is a gummy bear. But if you leave this longer, maybe 5 years, maybe 5 months, maybe 20 years, this will eventually rupture and eventually become this. Gummy bear, not gummy bear, no more. And it does disintegrate. Number two, one has to always assume, I thought this was going to be also ruptured because the MRI has been proven wrong, even though it's the best test out there. Everything has to be contained and the surgeon has to go super slow so that these outpouchings are not cut into. The blood loss is 3 cc's on the left and certainly also on the right. I'm very happy with the tedious meticulous dissection. The entire capsule indeed has to be removed no matter how thin it is. Yesterday I did the Facebook Live where this patient from Washington State, she had what was a capsule, explant that was done in September 21st, 2024, just like over a month and 2 days ago, and she came to me a month later for residual capsules because she was not improving. Remember, the whole explant surgery is about the capsule so that all of what is the capsule is removed along with the inflamed tissue and along with the implant as one system so that if it is indeed ruptured, it's all contained, there's no need for drains. And now the patient will have the peace of mind it was all removed in the en bloc fashion. And number two, that it is going to be tested to make sure that it's not that very rare CD30 analysis is going to be done, that very rare PLLC still must be ruled out. So I'm very happy and content. Please do your research, network, talk to the other patients. It is very important to do the surgery right and once. And the surgeon should and must be committed to an en bloc because you don't want to find out otherwise. I talked to a patient a couple days ago and she said she was going to get her surgery and her explant done under local. You do not want to do this under local. You can never remove this. It's not fair for the patient to get a local operation to remove the implants. So there you have it. This is Dr. Khan, Executive Plastic Surgery.